When a patient presents with widespread joint pain, the initial clinical decisions carry high stakes. Ordering broad blood tests too early can lead to diagnostic delays, and in inflammatory disease, lost time often results in irreversible joint damage. In a clinical setting, we define polyarthritis as the active involvement of 5 or more joints. We must first distinguish true inflammatory arthritis from mechanical wear. The hallmarks include visible swelling, localized warmth, tenderness, and morning stiffness persisting over 30 minutes. This condition follows a specific behavior. Inflammatory joint pain typically improves with physical activity and worsens with periods of rest. Reaching an accurate diagnosis requires identifying the physical pattern of involvement before reviewing laboratory data. Relying on blood panels without an established clinical pattern is a common diagnostic error. The body's physical presentation provides the necessary evidence to categorize the disease. The first essential filter in our diagnostic algorithm is the 6-week timeline. Acute polyarthritis lasting less than 6 weeks is often a self-resolving issue, frequently driven by viral infections or temporary crystal deposits. However, when inflammation persists beyond 6 weeks, the condition is classified as chronic. At this point, the primary suspect becomes a systemic autoimmune rheumatic disease. Established clinical guidelines mandate duration as the first step in the approach. This timeline acts as a sieve, separating transient illnesses from chronic autoimmune processes. Once chronicity is officially confirmed, the diagnostic focus pivots to identifying the specific way the disease is affecting the body's tissues. The first major clinical phenotype is the rheumatoid arthritis, or RA-like pattern. It is characterized as a chronic, additive, and predominantly symmetrical condition. It has a precise anatomical preference, targeting the small joints, specifically the knuckles, the wrists, and the small joints of the feet. A critical negative indicator for this pattern is that it almost always spares the DIP joints, which are the joints closest to the fingertips. This pattern results from synovitis, inflammation concentrated in the synovial membrane that lines these joints. This is a malfunction of adaptive immunity. It is driven by B-cell activity and the Th1 and Th17 pathways, and it is genetically linked to the HLA-DR4 marker. This adaptive immune response leaves behind measurable markers, which is why these patients often test positive for rheumatoid factor and anti-CCP autoantibodies. Because this is a systemic process, it can involve the lungs, cause rheumatoid nodules, or lead to inflammation in the eye. It also carries risks for the cervical spine. The RA pattern is a coordinated, symmetrical attack by the adaptive immune system, targeting the synovial linings of small joints. The peripheral spondyloarthritis, or SPA pattern, represents the immunological opposite of RA. Its physical presentation is often asymmetrical and tends to favor the large joints of the lower limbs, such as the knees and ankles. Unlike the RA pattern, spondyloarthritis frequently involves those distal DIP joints at the ends of the toes and fingers. We look for 2 specific physical indicators: dactylitis, where an entire digit swells uniformly, and distinct nail changes, such as pitting or separation from the nail bed. The underlying biology here is different. SPA is driven by the innate immune system, specifically the IL-17 and IL-23 axis, and is strongly associated with the HLA-B27 gene. This pathway is also linked to psoriasis, inflammatory bowel disease, and eye inflammation, along with cardiovascular risks like aortic root dilatation. Finding asymmetric lower limb pain combined with these skin, gut, or eye issues necessitates a diagnostic framework distinct from RA. A third pattern involves connective tissue diseases. In these cases, the most important clinical evidence is found beyond the joints. Vital clues include sensitivity to light, hair loss, oral ulcers, the Raynaud phenomenon, and skin thickening. These systemic signs, along with positive ANA and ENA antibodies, point toward conditions like systemic lupus rather than a primary joint disease. These divergent clinical patterns are determined by microscopic anatomy. As the data indicates, rheumatoid arthritis is a disease of the synovium, the lining of the joint space. In contrast, spondyloarthritis is a disease of the enthesis, the site where tendons and ligaments insert into the bone. Because small joints contain significant synovial tissue, they attract the RA pattern. The lower limbs, spine, and DIP joints are rich in entheses, making them the primary targets for SPA. In rheumatology, the specific structural target dictates the genetic profile, the systemic manifestations, and the required therapeutic strategy. Identifying the clinical pattern allows for the deployment of precisely targeted pharmacological treatments. For the RA pattern, the effective arsenal includes methotrexate, JAK inhibitors, and biologics targeting TNF, IL-6, or these cells. Utilizing IL-17 inhibitors for RA will result in limited efficacy, as it targets the wrong immune pathway for that disease. For the peripheral SPA pattern, clinicians utilize TNF and JAK inhibitors, along with the IL-17 and IL-23 inhibitors that are highly effective for this pathway. There are also specific contraindications. Hydroxychloroquine provides no benefit in SPA, and rituximab has no role in its management. This comparison proves why treating all forms of arthritis as a single entity is a clinical error. Prescribing a biologic without first determining whether the target is the synovium or the anthesis ignores the underlying biology of the patient's condition. The first rule of the bedside approach is to recognize the clinical pattern before ordering investigations. Apply the anatomical logic. Synovitis suggests an RA pattern, while enthesitis suggests a spondyloarthritis pattern. The immunological markers follow this divide. Autoantibodies align with adaptive immunity, while HLA-B27 aligns with innate immunity. A different path, a different target, better outcomes. Mastering this approach allows physicians to move past ambiguous laboratory results and deliver evidence-based personalized care directly to the source of the inflammation.